significantly raise a concern enough that everyone should do it, and fats, and takes it back to the liver to be repackaged and processed and sent out again. And of these X amount, certain amount had a vascular disease, and certain amount had heart attack. It doesn't mean it's you, because you have to make changes as opposed to just, I'm going to take a pill and hope for the best.
Hi everyone, this is Shreya from the HealthVan clinical team. We're excited to announce the launch of our specialized panel designed to assess heart health. This panel includes a comprehensive lipid profile along with advanced biomarkers such as apolipoprotein B and lipoprotein A. Our team recently sat down with HealthVan advising physician Dr. Richard Cohen to delve into the details of this heart health panel, discussing the valuable insights it can provide to patients, important considerations for its use, and strategies for tracking and optimizing heart health. Dr. Cohen is a physician with over 25 years of experience focusing on longevity and metabolic health. Now, without further ado, let's go ahead and get started.
Cholesterol in and of itself didn't work. It didn't work for the population as a whole. And let me back off. And with everything we talk about, and the piece that is always missed and continues to be missed because the model of Western medicine doesn't address this, is the individuality of the person. Um, got to keep in mind that any study that is currently done are done through randomly controlled trials in large population database that are matched within certain characteristics based on age, gender, so forth. They're not matched on individual biochemical markers, individual genetic markers, individual phenotypic markers, all these things that make us individual. So, the analogy I use is you could say cookies are bad and bananas are good. But if you're looking at blood sugar, one person may eat a banana and it drives his blood sugar up. With the cookie, depending on the cookie, which is made with almond flour and honey and some nuts and some fat, does nothing. Where vice versa, the other person eats the cookie and the blood sugar goes way high. So we're all individuals. So the way the model works is you find a molecule where we look at patterns and we say, does this pattern statistically significantly raise a concern enough that everyone should do it? Well, that's ridiculous. We're not everyone. It was the basis of our knowledge, and vice versa. It's like, is this molecule sophisticated or efficacious enough, and is the risk benefit strong enough that we can put it for everyone, because a certain percentage of people are going to benefit, and it may not help. It may not help you. It may not help 10 people, but it may help 2 people. So it's a lot of statistics. It's a lot of playing with numbers. So at the end of the day, does a protocol, does a change in behavior help you? And then you have to decide, how is it going to help you? Does it help you feel better? Does it help you perform better? Does it help you not get sick? Does it help you live longer? And then how do you decide that? Right? So how do we decide if something is going to help us in the short versus the long term? And it gets quite difficult. Um, the framework of saying that you're just going to lower some lipid levels for yourself and expect 40 years down the line you're going to get less disease and you're going to take a medication for your whole life, can fall apart pretty quickly, because what are the consequences? How is it affecting other biochemistry? How is it affecting your mitochondria? And we know statins, for example, affect mitochondria. Well, that's a bad thing, considering that mitochondrial reactive oxygen species and damage to mitochondrial DNA is a primary determinant of how long we live. So, okay, we lower our cholesterol, but we live less, right? So what's all-cause mortality? So we could go on. So, and I'm doing this purposely because it's super confusing and it's super nuanced, and things change all the time. But cholesterol, let's get back to that. Cholesterol is really important. has antioxidant capacity. It's been around forever. It gives the cell membrane flexibility, and many other factors. So critically important to have sufficient cholesterol. The problem is um, that how we process cholesterol can be an issue. And then what's happening at the inside of the arteries when we talk about vascular disease. Um, Cholesterol, because it's fat soluble, it can't float around in the blood. So the body uses something called lipoproteins. There's a whole variety of sizes. There's very low, low dense, high dense, small particles, and et cetera. So the two that we've become commonplace, and because they've been done forever, and they're sort of falling out of favor now because we're learning more and we'll learn more again, is LDL and HDL. In general, LDL is a wide spectrum of dense, low dense, so they're more fluffy, versus high dense, which is the HDL, right? High density lipoprotein and low density lipoprotein. But within that spectrum, there's variations of those sizes too. But in general, LDL takes cholesterol from the cell membranes that's been utilized and fats and takes it back to the liver to be repackaged and processed and sent out again, or broken down and metabolized. where, I'm sorry, yeah, where, let me backtrack. LDL takes it to the cell, HDL takes it back. HDL cleans up. So in typical, it was thought that LDL bad, HDL good, especially if you have too many LDLs, and not that simple, right? Um, LDL is important. It's not a bad guy. It just takes lipids to the cell. The problem is if the cell wall, the arterial wall, has been damaged or it's lost its ability to protect itself, then certain particles of LDL can be, we'll call it, more irritating, or more inflammatory. And those particles are apolipoprotein B, which is another type of protein that sits on this LDL molecule. And then there's another one that's called lipoprotein A, which is more genetically determined. Again, that is even sits on the apoprotein B, and then is even more irritating. When that occurs to a artery that is not healthy, it can cause inflammation. And it's that inflammation which causes buildup of plaque, and that plaque, which then can break off or clog the artery, can lead to heart disease, or it can lead to loss of vascular elasticity, or it can affect the brain. So that's what we want to try and avoid. The lipoproteins aren't necessarily bad guys. It's the damage to the arteries. It's the ability of the arteries to protect itself. So the arteries are like, they have a hard outer side. If you look at them like a hose, they have a muscular inside, and then they have an interior side, which is called the endothelial lining, which has something called a glycocalyx, which has these they're like little hairs. When our diet is deficient, or when it's high in sugars, or the wrong types of fats, or when we're spewing off reactive oxygen species due to an unhealthy mitochondria, that inner lining becomes damaged. So now you don't have a lining that protects the artery, and the ApoB and the lipoprotein A, which are more irritating, can damage that lining. And that starts the process of disease. So that's a very simplistic form of what's going on. And you can see what we have is we have the fats, we have the carriers, we have the arterial damage, we have the inflammation, and they all need to come into play. And you don't have to have them all. I mean, you can have arterial damage and not a lot of lipoprotein A or ApoB and still have a problem, right? Because the artery now has lost its flexibility. Or if you have extreme amounts of the ApoB and lipoprotein A and your arteries are pretty good, that still can cause damage. figuring out who's at risk and what you can do about it. Because I've seen, oh, we can, so I've seen people with both ways have issues, and you wouldn't expect that. So does that mean you should take every person and drive their LPA down and drive their ApoB down? That's what some people suggest you do. Um, it's expensive to do that, and the cost benefit analysis is unclear for each person. So, this is where you start to have to look into what are my real risks. It's not just the number, right? So this is where you start to look into, one, metabolic health. If you're metabolically healthy, if you can handle glucose, if you're not eating processed, omega-6 oils that are oxidized, if you're not over stressing the arterial system in a whole variety of different ways. When that's working well, the ApoB and lipoprotein A is much less of a problem on the body. And you can look at studies as I go back to the beginning. We don't look at studies with regard to metabolic health. Now, granted, 90% of the population is metabolically unhealthy. But if someone wanted to address vascular disease, fix metabolic health first, and that's a priority. If you don't want to do anything, then you can play with the magic of pharmaceuticals and hopefully get you there. But the thing is, if you don't address metabolic disease and you're fixing your lipids, you're playing whack-a-mole, because the metabolic disease you may have stopped the metabolic disease from making you susceptible to the ApoB lipoprotein A damage, but cancer could get you, or inflammation, or immune suppression from that metabolic problem, or advanced aging. So the lipids, fixing it doesn't make you feel better. It doesn't make you healthy. It reduces your chance of heart disease or getting a heart attack. The interesting thing is, just to throw out, is there's a lab called Prevencio Med, and they use particular algorithms, and they've studied all these different molecules and markers in the body, and using artificial machine learning or intelligence and looking at patterns, they're able to, within 90%, predict through a blood test whether you have vascular disease or whether you're going to have a major event within the next year or so. uh, what they don't look at is lipids. None of the markers of the four addresses lipids, because lipids are a bystander. They're not a sign of damage to the heart muscle. They're not a sign of damage to the vessels. They're not a sign of clotting. And these are much more important to address. And I'll say it, ultimately, we address lipids because there's a lot of money to be made in lipids. And yes, there's some benefits for sure. But, from a foundational fix, that's not what Western medicine does. So, HDL, cholesterol, triglycerides. We didn't talk. Triglycerides are the other key marker. Triglycerides are your body's ways of storing fat. They take sugars and convert those into triglycerides, which then get stored as fat, or they stay in your body. So people who are eating too many carbohydrates for their capacity will have higher triglycerides. And that sort of goes into looking, one of the key markers is this triglyceride HDL ratio should be about 1 to 1. And if not, it just says that your body is not handling glucose well and you're metabolically unhealthy. What's interesting is we don't look at triglycerides very much, traditional medicine. I do. It's one of the insulin and triglycerides are the most important marker, from a simple assessment. Western medicine doesn't look at it because they found that if they treat triglycerides and try and bring them lower, it didn't help heart disease. And they said, well, triglycerides doesn't matter. Well, in and of themselves, they don't, but high triglycerides are a sign of metabolic dysfunction. So the Western medicine model of treating each, micromanaging the disease, instead of saying, how about if we fix the cause of the triglycerides by creating insulin sensitivity and changing your diet and getting you active and all the things that we know plays a role, and rapamycin plays a role if done properly. That'll work. Well, that's not a medicine. So we're going to forget triglycerides. And then they tried to say, well, we know HDL is good. Let's try to boost that. Well, that didn't work either, for the same reason. But recently, they've learned that HDL, it's not necessarily the number, because there's been some indication some people have very high HDL levels and they're not cardioprotected. Again, HDL is a subsequent marker of insulin and metabolic health. Well, it turns out that HDL, as you recall, removes the lipids, the damaged oxidized lipids, and takes it back to be repackaged. Some do it better than others. So if your HDL is efficient and more effective, you're going to have a better protection. And that goes along with metabolic health as well. And there's a new marker that's being looked at. It's called cholesterol flux. It's how you can move cholesterol out of this endothelial lining and get it back to be processed, because that's very important to remove it, right? So it's like, even if there's damage, you want to get it out of there. It's like, get the bad guys away, move them out, move them on, and, you can take care of cleaning up house. The last piece to address is, right now we're looking at numbers. You have no idea. How do you know? If we go back to, if you do a randomly controlled trial that said, well, we test 50,000 people and X amount who had these particular numbers, but we didn't look at other factors, but we just said X amount of people had these particular numbers, and of these X amount, certain amount had a vascular disease, and certain amount had heart attack, and certain amount may have died earlier. Um, it doesn't mean it's you, right? We have no idea what that means to you. And the old thing, 40 years ago or 30 years ago in medical school is like, the first sign of heart attack or heart disease for most people. And, this is when we didn't see things as clearly. It's like, well, hypertension, heart problem, blood sugar control, heart problems, high cholesterol at the time, heart problems, those sort of overweight, right? So we're looking at really general markers. 50% of people had none of those and they had heart disease. Well, what did that tell us, right? We're not looking at the right things. If only half of the factors that we thought were important actually caused the problem. So we need to be more precise. And fortunately, we can do that. We can look at one, metabolic health. That's really critical. We can look at factors such as insulin. We can look at HDL triglyceride ratios. We can look at break down all these lipoproteins and oxidized cholesterol. So there are some very sophisticated panels that'll tell what the enzymes, and is there enzyme damage on the arterial endothelial lining? What's going in? Is there a plaque? Is that releasing something? Are you someone who absorbs cholesterol too rapidly, or how are you breaking it down? What's cholesterol flux? And so but again, that's still numbers, and you can take that and analyze those and be much more sophisticated, and you come up with this Prevencio Med marker. So that's one piece, but that only tells us what may happen. It doesn't tell us what's happening. So the next thing is, well, let's look at organ function. And you can look at organ function, you can look at the arterial lining, and you can look at how that artery is responding, because that's a more important, just because there's bad guys around doesn't mean they're going to break into your house, right? They may be there and they're just having a party in the street. So you can look at the arterial lining, and it's one of the ways that high blood pressure is a very important thing, in the fact that high blood pressure could be for a number of reasons, but it says your arteries aren't very elastic. And there are tests such as something called an endopat. You can look at arterial elasticity. You can look at the ability of that artery to flex and open and close. So that's a really key marker. So it actually tells you arterial health. There's another test called glycocheck, which actually uses a camera under the tongue, but you can actually look at that glycocalyx from this vasculature in your tongue, and it correlates with the glycocalyx in the arteries. You can actually see that improve if you make certain changes or certain nutrients in your lifestyle. So that's a good sign. So if that's destroyed, you're at risk. You can also look at the artery. So if someone who is at risk for disease, right, coronary calcium scores, that tells us not how much plaque, but it tells you if there's calcium. And if it's very high, it's typically not a good thing. If it's very low, that's better. And most likely, if it's very low, you don't have soft plaque. And in fact, one of the ways that you want to treat the soft plaque is to get it to calcify. So using a calcium score, which is low radiation, but then you have more sophisticated tests like a Clearly 3D, where it's actually an arthrogram with a dye, and you inject that, and you are exposed to radiation, but you can pick up plaque and soft plaque. So if someone's at risk, it's not something you'd want to do all the time. But if you have a strong family history and you have lots of imbalances, you're metabolically unhealthy, sure, go ahead and do that. There's a new test that just came out of the UK, which is actually in between those two, the coronary um, Clearly 3D arthrogram involves radiation and dye, which is, you're exposing yourself to some risk. This new test uses the coronary calcium, the CT, which can be lower radiation score, and they use an AI to actually visualize inflammation, which is the most important thing. It's how inflamed that the lining of the arteries are. So this is a quite cool test. So now you can take a calcium score and you can overlay that with inflammation. So that's a cool test that's coming out. Um, you can look at carotid ultrasound. It doesn't exactly correlate, but you know what? If your carotid lining through an ultrasound are clear, you can do that. It's cheap. It's non-invasive. It's no radiation risk. You're pretty dang good. If you have problems in your carotid arteries, and you can see what's old and what's new, then you might want to progress and look at things more um, preventively, or more again, intensely. That's where you might want to step up to test. And they're not inexpensive, but $1,000, $1,500 to know if you have disease that theoretically could end your life sooner than later is probably worthwhile spending. The last test, which I find really most useful, is because it's the most functional, and you can sort of pick and choose one in each category, is a coronary pulmonary exercise test, which basically is like a VO2 max test, but it looks at other markers. So it looks at your oxygen, carbon dioxide, at what point you switch from burning fat to glucose. It looks at your max ability to generate energy. It's a proxy of mitochondrial function. And one of the key things you can do is look at heart rate versus stroke volume of the heart. If the heart rate should be fairly linear, that means as your heart rate increases, the amount of blood that's coming out should increase accordingly. That means the muscle's keeping up. If that begins to lag, if like your heart rate's increasing faster and faster, but it can't pump as much, that says, one, the heart's not efficient, and it says, two, the blood vessels aren't dilating. They should be opening up to allow that blood to come out. It's sort of like having a thin hose and a thick hose. You just can't get fluid through that hose because the hose and the artery are just not relaxing sufficiently. And that has to do with nitric oxide, and it has to do with stress signaling, and the autonomic nervous system, which we haven't talked about, which plays into blood pressure. And actually, there's another a really useful simple test as well, is to look at 24-hour circadian blood pressure. Um, if your blood pressure is good, what's that tell us? It tells us that your nitric oxide is good. It tells us that the endothelium of your lining, or the muscles, have the ability to relax. It tells us that your nervous system, isn't overly amped, that you're causing, norepinephrine and cortisol to increase, and that's causing the blood vessels to constrict. Um, there is a new, you can do it with, you can check morning blood pressure, which is okay, but if you have a 24-hour, you can sort of gauge how it's going over time. And there's a new device, and we have all sorts of cool devices. It's called Atkila, Atkila. It's only available in the UK right now, and Ireland. It should be available next year in the US. It'll be a watch that measures blood pressure continually. And most people, well, I don't have a blood pressure problem. And yeah, and maybe you don't, but it's the ability, you have to think differently, the ability for the body to react and following that blood pressure as a circadian rhythm is really important. So we don't want to wait to say, oh, my blood pressure is high, that medicine decided that now I'm at risk. Well, again, we're looking at large scale studies. What you do know, if your blood pressure is running high, there's an imbalance, there's a metabolic health imbalance, there's a stress imbalance, there's an arterial wall imbalance. And ideally, the less the more consistent that is low, the more your blood pressure is lower in the morning, which is a sign of hormonal health, the healthier you are. So, it's ironic with all our testing, available. But one of the things we've done for 100 years is look at blood pressure. Now, with the ability to look at blood pressure on a consistent level, I might even go back and say it might be one of the more important simple signs. Because if your blood pressure is nice and flexible, we can go back through that whole gamut of whatever I've talked about and said everything is good. Doesn't mean there's not another issue, but one of the major pieces is taken care of. So I would tend to guess, someone with a blood pressure that runs 110, 115 over 75 consistently, 70, very rarely has heart disease. Because not because, the pressure, and we tend to think of blood pressure being too high causing shear stress on the arteries, and it does that, but it's what the cause of the blood pressure, right? So what's causing all the other issues that may cause the blood pressure to be high is a core problem, for all these other factors that we spoke about. So yeah, there's a lot there. People can listen to this, and I'm sure I've missed a few points or maybe not got everything exactly, but the key point of this message is lipids, one small piece of it. If you're really looking at health, we need to look at it from an organ perspective, from a biochemical perspective, from a functional perspective. And putting these all three together, now you can get a complete picture of your health. And when you do that, you're not just reducing your risk of heart disease, you're making yourself healthier. And I left out iron, which is another key piece that's missed. Iron or high iron or iron dysregulation in the body, to me, is way more important than lipids. Iron is an oxidant, right? It rusts. It causes reactive oxygen species to develop. So my goal with people I work with is getting iron levels down to the minimum that we would need to develop or carry oxygen and provide that oxygen to the mitochondria to function. We have lots and lots of iron in our tissues that's basically stuck there because most people are iron overloaded. So giving blood certain nutrients and certain type of training can help that iron begin to clear out of the tissues and to be used and utilized. So that's a really important piece that is missed. And about 30 years ago, there was a Dr. Sullivan that his whole career was based on iron and cardiovascular disease. And, it's sort of just never quite, we know it's a problem, but it just hasn't caught on for, let's say, financial. It's just there's not a magic molecule treatment for this. It's a non-specific marker of inflammation.
Mhm.
So it's certainly, if someone has a C-reactive protein that's elevated, there's inflammation somewhere in the body, and there are a number of different markers that will link to inflammatory status, fibrinogen,
Mhm.
homocysteine. Each of the recent one I read recently was there's two major liver enzymes that we look at, and the ratio from one to the other, if it gets over two, is it's like one of the strongest risk factors for someone having a second heart attack, right? So there's these aberrancies that occur, within the chemistry, within the biology, as we spoke about, and what that says is, right, that it's not lipids only, right? And you can look at oxidized cholesterol. So you need to look at all these factors combined to get a sense of what your overall state of health is. And, unfortunately, that takes time. It takes clinician experience, to look at someone from more of a functional state of health, as opposed to, you have this disease, I'll give you a medicine for it, and or we'll treat it, we'll intervene. So it's a different way, and we're not trained that way in school. So it does require more effort, and it requires more effort on the person, because you have to make changes, as opposed to just, I'm going to take a pill and hope for the best. Um, you have less reactive oxygen species in your mitochondria most of the time, right? Unless they're overtrained. But in most of your mitochondria are functioning more healthfully or more efficiently. So that's one thing. Typically, there should be less inflammation. Maybe the trained cyclist isn't the best example, because I see people overtrain, because it all depends. Are you doing it for fitness? Training for fitness is not the same as training for performance. And you put yourself at risk for that, because you could overload your ability to handle those stressors. So, so you're going to have better ability. You're going to handle glucose more efficiently. So you're not going to have insulin that's in excess. Insulin is a inflammatory trigger to the cells. Your blood is going to clot less. It's going to be more fluid. It's not going to be as heavy or thick or viscous. Is another piece to it. The glycocalyx and the arteries are going to be much more pliant and resilient, as opposed to stiff. The heart is going to be much more efficient in its ability to um, provide oxygen to the tissues and pump blood. Those are the big things. And the other, typically you have a better you can have a better ability to respond to a stressor. So one of the we tend to think of training, I'm going to push hard and that's where I'm getting my training. But in actuality, it's the ability to recover from the stressor that's really more important, and that's the resilience. So if someone's training, the best marker or a better marker is not like how well, it's nice to know where your heart rate went to, and it's more important is how fast your heart rate can go back to normal or go back. So an example would be, if I did a hard effort, my heart rate can get, let's say 165, and if I just pedal lightly, so let's say I've gone from 250 to 300 watts on the cycle, I'll go to 165, then I'll drop down and pedal 40 watts. And it'll take me 2.5 minutes to go from 165 to get into 130s. Pretty good. Yeah, pretty good. I'd like to do better. My wife, who is a cyclist and super fit, she'll go down like in a minute, less than a minute. She'll go from like 160 to 120 in a minute. So her ability to recover from a hard effort is ridiculous. Like is a ridiculous. So anytime she's pushed, she's never going to have vascular, heart problems in that regard. Where if you look at the old people, where men, traditionally had their heart attacks was like after a workout. They did a training, they went in the shower, they didn't recover well, and they found them dead in the shower, or at the end of a hard effort. They didn't have the resilience to recover. One of the benefits from high intensity or interval training is that exact piece. Is it's not It's not the intervals that you're going up, it's the ability to train to go down. So always think about what I can do to relax, calm myself, breathe, and get heart rate to come down faster, and use that as your sign of fitness and resilience, because that's part of that autonomic nervous system, which can trigger a problem.
Our talk with Dr. Cohen shows that heart health is not just about numbers. We need to look at each person's unique situation. The Heart Health Panel is a starting point to improve heart health, showing where you stand and if more tests are needed. To learn more about heart health and the Heart Health Panel, click the link in the description below. We'll see you all next time.